Good evening. So basically I'm substitute here. So we'll start off with this one. So we'll have a case-based discussion of approach to chronic diarrhea. Dr. Yadavarasi, consultant from Sanjana Hospital, Specialty Hospital, will be the moderator. The panelists are Dr. Giridharan from MMC, Dr. Giridharan, Dr. Divija, SRMC, Dr. Rajesh Kumar Jaina, KMC, Dr. Shiva Prasad, Stanley Medical College, and Dr. Manjunath is held up after the FAT exam, so he won't be able to make it. So the questions can be
directed.
Redirected. So I think chronic diarrhea is one of the most challenging things in our clinical practice most of the times. So let's see how we proceed with this. Over to Dr. Yadavarasi.
Good evening, respected teachers, postgraduates, and my dear friends. I thank Perma sir for this opportunity. So for the next few minutes, we'll have some very common cases which we come across every day in our practice, and we'll try to take 3 cases and discuss some exam based, as it's a PG session, we'll discuss exam based questions based on it, based on the cases. So we'll go directly into the case. The first case, she is a 24-year-old female with chronic diarrhea for more than 2 months. She's been on and off antibiotics and she's found some partial relief. It's a small volume stool associated with blood and mucus. It's around 4 to 5 episodes per day and associated with colicky abdominal pain. She also gives history of tenesmus. It's a very simple case and a very straightforward history. So there's no history of any NSAIDs or alternate medication intake. There's no history of any cough or no past history of any tuberculosis, no history of thyroid or abdominal surgeries. She does not have any history of significant weight loss. On examination, she appears pale. Her heart rate is 80 per minute. She is afebrile. Abdominal examination, there's some diffuse lower abdominal tenderness. Rectal examination, blood stained. No mass felt. So whenever there's a yellow colored slide, then that will be a question slide for you. With your name it comes, you can just try to answer. So Dr. Giridharan, how do you classify chronic diarrhea? What are the types of chronic diarrhea? What type of diarrhea this patient has? Where do you want to localize the diarrhea to?
Ma'am, types I will classify as small bowel and large bowel diarrhea, and again inflammatory and broadly I will classify as functional and non-functional, and functional and organic diarrhea. Then I will think of either small bowel or large bowel. Then I will think of whether it's inflammatory or non-inflammatory.
Okay, good. So you want to classify into inflammatory or non-inflammatory.
Yes.
So that's how we classify. So non-inflammatory will be all your secretory, osmotic, fatty diarrheas and functional diarrheas. Inflammatory will be again most common being IBD, and then other etiologies, colorectal cancers, then invasive infections comes next, and then if there's a history of radiation induced colitis, eosinophilic colitis, all these can come under inflammatory. So what type of diarrhea this patient has? I asked you one more question, small or large bowel?
This patient has a large bowel type of diarrhea, having mucus and blood stain.
Then?
And tenesmus is there, ma'am. So the site of pathology is probably rectal.
So you want to localize it to the large bowel?
Yes, ma'am.
Very good. So these are the common differences between small bowel diarrhea and large bowel. So this patient has, and frequency is also important. Generally if you see, the small bowel diarrhea has less frequency but they become more tired. But large bowel diarrhea has more frequency but they don't lose that much of weight. Then again urgency and tenesmus, as in this patient, points towards a large bowel diarrhea. Rectum is involved and fresh blood again points towards a large bowel diarrhea.
One basic question.
Yes.
When will you say acute diarrhea, when will you say chronic diarrhea?
So any diarrhea beyond 2 weeks is persistent diarrhea, beyond 4 weeks is chronic diarrhea. Okay, and Dr. Devija. So how do you get this case in your exam? So what do you want, how do you want to conclude?
So considering her age and involvement of large bowel, it's probably a inflammatory type of diarrhea.
So you want to say chronic inflammatory
diarrhea. So it's probably an IB, inflammatory bowel
Involving the
disease.
large
bowel.
So that's how you have to say chronic inflammatory diarrhea involving the large bowel. So what are your differentials you want to offer?
Ulcerative
This particular
colitis is-
patient.
Ulcerative
Okay,
colitis
very
is
good.
one of
Ulcerative
the
colitis will be your
reasons,
first one.
Yes, ma'am.
Then?
Solitary rectal syndrome with
Do you think that will
diarrhea
come?
and
That will come second.
Crohn's.
She doesn't
disease.
have any history of chronic constipation,
ma'am.
no history of manual evacuation of stool. So
Okay.
SRUS may come as one of the rarest differential, but may not come as a second.
In inflammatory itself, ulcerative colitis and Crohn's.
Crohn's
is
colitis.
possible.
Rectum can be involved in Crohn's colitis.
Very rare.
40%. There
Yes,
can be
ma'am.
40%
Yes, ma'am.
involvement in Crohn's colitis. Then any other etiologies you want to consider? This, I think everyone will say IBD first. So if the examiner wants more differentials, what would you like to give?
Tuberculosis.
Okay,
can be a
tuberculosis is
possibility, ma'am.
fine. So how often tuberculosis involves rectum?
Rare. ma'am. No.
Rare. You should say
No,
always in
it's not. It's
percentages, less than
idiosyncratic,
5%,
less than
1 to
five.
2%.
Okay.
Then any other differentials? That's all?
And
Yeah,
Two
amoebic
years, yes,
colitis
ma'am.
also you should
Yes,
mention.
ma'am.
Common
Yes.
amoebic colitis,
Colitis,
and then still colorectal cancer. We do
And,
see malignancy in young individuals, and eosinophilic colitis very rare. So this is one of our patient with rectal tuberculosis. He had only a rectal tuberculosis, alcohol consumer, and treated with ATT, and he settled in. After that, the post-treatment colonoscopy was absolutely normal. Okay, now how will you evaluate this patient? What are the tests needed for your evaluation?
I'll start from routine blood investigation test, ma'am. I'll start with CBC. In CBC, there will be, as this patient having bleeding episodes are there, there will be anemia will be there. Patient may have thrombocytosis will be there.
Okay.
Then electrolyte imbalance may be there in the sodium potassium loss can be there. In LFT, there can be a loss of albumin can be
so you want an
hypoalbuminemia there. So routine
LFT.
blood investigation I'll do. Then followed by fecal calprotectin in this patient will be elevated. Then after that I'll
What is the test to diagnose?
colonoscopy I'll
Do you want an upper GI endoscopy in this patient?
No, ma'am, I'll first want to do colonoscopy. in this
So
case.
that's not needed because we know it's purely a large bowel type of diarrhea, so probably ulcerative colitis. So hemoglobin is 8.5. As you said, she has iron deficiency anemia, low serum iron levels. Peripheral smear showed microcytic hypochromic pattern. Her CRP was 30. LFT albumin was normal. Ultrasound showed some bowel wall thickening. As you said, her fecal calprotectin was high. It's not a very mandatory test, but if the patient is affordable, it's better to do because it's very helpful for follow-up. So we proceeded with colonoscopy and biopsies. So this is the colonoscopy picture. She had diffuse erythema, erosions, loss of mucosal and vascular pattern involving the entire left colon, starting from rectum up to splenic flexure. The right colon, IC valve, ileum are all normal. So biopsies as how we normally get chronic active colitis, features suggestive of inflammatory bowel disease. So now the question is, what is the earliest histopathological or biopsy finding in IBD? That is, with what finding the pathologists generally say this is not an infective colitis, this is a inflammatory colitis. What is that early histopathological finding? Some histopathological findings, it's important for us also to know. So what is that earliest finding which you see?
Cryptic abscess.
Before that?
So there should be evidence of chronicity, which will indicate chronicity. Cryptopsis is there even in acute infection. It doesn't differentiate between.
But yes, but crypt branching is more of inflammation.
So what is the mechanism of diarrhea in inflammatory bowel disease?
So there's that's.
It is
Questions can be directed to
exudative or absorptive, defect in absorption,
Everything,
or
sir.
increase
It's
in
a
the secretion.
multifactorial pathogenesis.
What is
sir.
the role of the
Genetic-
bacterial toxins and immune
Yes, sir.
cells?
It's post-infectious in everything, sir. So it's a multifactorial pathogenesis.
What is the role of cytokines and on the immune cells?
Yeah, it's more of a clinical discussions. Yeah. So she'll be, PGs will be answering the questions. It's more of a clinical discussion.
So, okay. So this finding, if you would have seen, basal plasma cytosis. So this is the earliest finding which is highly reliable that it's not an infectious colitis. So that is why that name is, there's an increase in plasma cells in the lamina propria between the crypt bases. So that's why that name basal plasmacytosis. So some of the other common things which differentiates from an infective colitis is crypt branching. Again, crypt branching is never seen in an infective colitis. Similarly, Paneth cell metaplasia. So if someone is interested, they may ask you especially left colon. Right colon we don't see Paneth cells. Left colon Paneth cell metaplasia is a abnormality. Right in left, sir.
No, it is not there in colon. It can be sometimes there. It is a cell of the small intestine.
Small
So
intestine.
if it is there in large intestine, in children it can be there on the right side. Generally, it is not there in the left side. If you see Paneth cells on the left colon and even in the right colon in adult,
Right colon it's normal cells. It's to see it in the right colon is normal. That's what I.
So then it means that it is a chronic.
The extension to the left colon, it means a
It means there's some. It means there's inflammation.
It means it's a chronic.
Inflammation. So how do you assess the severity in IBD, ulcerative colitis? So one by clinical parameters and laboratory, the other one by endoscopy. So you can answer both.
True criteria.
Very good. So what are the parameters? Quickly you can just tell me the parameters which comes under true love.
Loose stools episodes. Loose stools
Number of
episodes.
episodes, okay.
Bloody stools.
Mm.
Temperature. Heart rate, temperature.
Yes.
And then
The laboratory parameter, anyone
CR,
can answer.
ESR,
Or CRP.
CRP.
Okay. So with this we categorize into very quick score. We can just quickly do it: mild, moderate and severe. So probably our patient will come under a moderate moderate to severe ulcerative colitis. What are the endoscopic criteria for severity?
UCIS score and Mayo score.
And Mayo score, correct. So these two, again, if the score is 0, then it's normal Mayo. 1, it's erythema, decreased vascular pattern and mild friability. Again, the score is 2, then it's marked erythema, absent vascular pattern, friability and erosions. And 3 is spontaneous bleeding and ulceration. So our patient had around 2 to 3, Mayo score of 2 to 3. So how will you treat this patient? So now we have classified this into mild to moderate, moderate to severe,
Yes,
and
ma'am.
acute severe ulcerative colitis. So,
Ma'am, mild to moderate, we can start with mesalamine itself, or otherwise we can start with steroids also. For moderate to severe, we will definitely start with steroids. And then over 2 months, we will start over the course. Depending on response, after 2 weeks we will start down titrating, and then we will maintain with mesalamine.
so what is the minimum maintenance dose for an adult patient with mesalamine? You can't give less than 1.2 grams.
Okay.
So that is a required dose. So for management of mild to moderate, the first line is, as you said, oral 5-ASA, plus you can also give topical or rectal 5-ASA. And if it is moderate to severe, as in case, so this patient was initiated on 5-ASA and corticosteroids, and she is doing well clinically. She is yet for a follow-up. So what is the treatment guideline for acute severe ulcerative colitis? So that's
for
a very
acute severe ulcerative colitis, we will start with we can start with steroids and look for response on day 3.
IV corticosteroids.
Yes, ma'am. IV corticosteroids and look for response on day 3. If responding, then we can continue steroids. And then if it's not responding, then we can either go for infliximab, or if not available, then we can go for tofacitinib also, ma'am.
Or upadacitin, that
Yes.
is also there approved now.
Okay.
So before that, you also need to.
Is there any role for cyclosporine?
Yes, sir. As a second line after steroids, as a second line agent, we can offer cyclosporine, sir. IV
So-
cyclosporine.
So the
Steroids, you said after the loading dose, no? It's 2 weeks. At least 4 weeks you give the maximum
Okay,
dose
sir.
and then taper.
Okay,
2
sir.
weeks will be too early.
Okay, sir.
We'll see a flare again if you.
Okay, sir.
So in the AIMS criteria, they have the stool calprotectin of cutoff of 1000. So read that paper by Govind's group. AIMS is All India Institute of Medical Sciences criteria for management of acute severe ulcerative colitis based on stool calprotectin. So they assess the stool calprotectin day 1 and then day 3, and based on that they take a call.
Okay.
So as you said, rule out infections. Even there's infection, you need not stop giving steroids. You need to treat that parallelly and start on hydrocortisone, 100 milligrams IV TDS, and then assess on day 3. That's very important. And then if the patient is not responding, then go for IV cyclosporin or infliximab or tofacitinib. That's also included in ASUC criteria now. But if the patient is responding, then transition to oral steroids. And the next assessment is on day 6. So if the patient is responding well, then maintain the patient on infliximab or tofacitinib. If there is no response, then plan for surgery. Surgical management will be the option. What are the prognostic indicators in acute severe ulcerative colitis? There are many, so but you can just mention 1 or 2.
Inflammatory markers.
So one is including inflammatory markers. What is that
based on
scoring?
clinical scoring, based on True Love with score also can be used
then
based on
any
clinical
other,
improvement in patient.
The name of the scoring. So one is La et al. Score, which includes CRP. This is an article which has multiple scorings for ASUC, but you need not know everything, but the important ones. La et al. Scoring, which is with CRP and albumin, which decides in-hospital colectomy, how many patients can go into colectomy, and Oxford-Travis scoring, where on day 3 of steroids also patient continues to have more than 8 bowel movements, and then this patient is not responding to your treatment. So these 2 are important. So the final question on this case, what are the causes of rectal sparing? Sometimes ulcerative colitis can have rectal sparing. There are 4 causes for it.
A patient treated with mesalamine enemas.
Okay, correct. On treatment.
And pediatrics patients will
Yes,
be
pediatric onset ulcerative colitis, rectum can be spared. Anything else? Associated with something else. When ulcerative colitis is PSC. Yes, so that is one. And one more is even in sometimes in severe colitis or fulminant, that is said in textbooks, so it can be spared. So you should know the association of PSC with ulcerative colitis. So someone who has ulcerative colitis has only 2 to 8% of PSC, but someone who has a primary PSC has a 70 to 80% chance of developing ulcerative colitis, and there is a slighter high risk for CRC, colorectal cancer, in associated with PSC. What does the X-ray show? Last one, X-ray. So suddenly a patient who is having severe diarrhea, the diarrhea completely stops and the abdomen is very silent.
like megacolon.
It's a complication of ulcerative colitis.
Toxic megacolon. Toxic megacolon.
Toxic megacolon. Criteria for toxic megacolon?
Is more than 6 centimeter.
Of which colon?
Transpose.
With systemic toxicity. Patient will have tachycardia, fever, all that. Okay. So, okay, we'll go on to the next case.
So just 1 second.
Yes,
So that initial classification, I think it's better to have watery diarrhea, fatty diarrhea, and bloody diarrhea, because inflammatory is histological. So some of the examiners, like in the syndromic, you can just put chronic bloody diarrhea, and then give a differential for that. Because when you say inflammatory is actually a histopathological, whereas the other 2 are macroscopic. Watery, fatty is all macroscopic. So suddenly the third one comes as inflammatory, which some of the examiners feel you should call it as a bloody diarrhea. So that classification seems to be better, so that you will have more differentials for your bloody diarrhea. You cannot say at the first instance it is inflammatory. You understood that? The initial classification, it's easy, you put in watery diarrhea, which can be osmotic or secretory. Then you have the fatty diarrhea, which is pancreatic, and the third one will be bloody diarrhea rather than inflammatory. And in inflammatory, then you bring in the third will be a bloody diarrhea, in which you bring in all the other differentials then it's easy. Then you'll have all your differentials for the The other important question that's often asked is, patient comes to you, it's only 2 months. How will you know it's infective or is it an IBD? So what would you do? Always assess the patients after 3 months. You have to reassess the patient. At 3 months, if you find that the patient's got branching, then what you're dealing is chronic IBD. But if the colon is totally normal, histopathology is normal, then because you're labeling the patient for lifetime as IBD. Have you followed that? So reassessment is something very important, especially in 8 weeks diarrhea. All your other Yersinia, all those things will come. So this question is often asked. Very difficult, extremely difficult. Infective colitis versus IBD, extremely difficult at 8 weeks. But then you're going to label the patient for lifetime. Understand? So always reassess the patient after 3 months. And at 3 months you will do histology. If histology is normal, that what you're dealing was an infective colitis. So these are some of the viva questions that are asked. Please read the AIMS criteria for acute severe ulcerative colitis and management protocol.
The better surety that it is a inflammatory bowel disease. As madam says, you're labeling him for lifetime. So it is better. In fact, some of the books says you wait for 6 months, 1 year before labeling them as ulcerative colitis or Crohn's.
Okay. Thank you, ma'am. We'll move on to the next case. So here we have a 31-year-old female. She is married with history of cesarean section 7 years ago. So her history is 2 to 3 episodes of watery stools per day, no mucus, no blood. She also gives history of low-grade fever for 1 month. Loss of appetite is there, significant loss of appetite and significant loss of weight, more than 8 kilograms over 2 months. She also gives history of some abdominal pain over the right lumbar and lower quadrant region. There is no history of any diabetes, hypertension, tuberculosis in the past. She has pallor, her BMI is only 19, there is no pedal edema. Abdominal examination, no mass felt, there is right side tenderness. Rectal examination is normal, no fissure, no perianal fistula or no abscess. So what are your possible diagnosis differentials with this patient's history?
Patient is having a small bowel diarrhea.
How did you say it's a small bowel diarrhea?
Less episodes are less. Patient has no blood, no mucus.
Okay.
Patient has
Significant weight loss.
Also patient has pallor on examination.
Okay.
It's also iron deficiency. So patients, I go for main right lower quadrant tenderness. It indicates ileitis with weight loss. So patient age, considering patient age 31 years, so can go for TB.
You.
Yes. Watery. Watery diarrhea can be osmotic diarrhea or secretory diarrhea. Secretory diarrhea.
Is the weight loss proportional to the 2 or 3 motions? Weight loss seems to be out of proportion to the diarrhea of 2 or 3 times, isn't it? What will you ask? You say small bowel diarrhea. What are the other points which will help you? You don't want to look at the stool?
Yes, sir.
For what?
Very fat.
Fat you can't see. What can the patient see? If it is small bowel, if it is malabsorption, maldigestion. Kadile, kotamille, tomato, all that can be seen, isn't it? You must ask, do you see any food particles in the stool?
So osmotic and secretory,
Osmotic
as
and
ma'am
secretory.
asked, what is the difference?
Osmotic diarrhea is improves
Anything
with
with fasting, yeah.
Improves with fasting. Secondary diarrhea does not improve with fasting.
Does not improve with
With
fasting.
fasting.
Generally occurs with most neuroendocrine tumors as well, the
Neuroendocrine
secretory type of diarrhea. Okay, so what are your differentials here? You said before.
Secondary diarrhea can be due to infections.
You want to rule out tuberculosis. You said before.
Infections.
Okay, infections. You want to consider infective diarrhea.
Infections.
Okay, then.
Can be due to endocrine causes. Or,
Okay.
or can be due to dysmotility, intestinal dysmotility.
She
So
had
you will think
history
about the
of,
giardiasis
she had
and
history of
cryptosporidiosis,
Yes, sir.
giardiasis. You will think. What test you will ask for giardiasis? You examine the motion or you ask for ELISA test? ELISA is specific for giardiasis rather than examination of the motion.
So she had history of low grade fever since 1 month. So she has more constitutional symptoms as well. So okay, so tuberculosis is 1. Then
Endocrine tumors, any
okay, you want to include that.
endocrinopathies.
Okay.
Malignancies,
Yes.
malignancies, color. HIV, HIV related diarrhea, opportunistic infections, Cryptosporidium parvum.
The large volume diarrhea, small bowel diarrhea. What about small bowel bacterial overgrowth?
SIBO.
How will you diagnose SIBO?
So diagnosed by means of jejunal aspirates, coliform count more than 10 power 5 colony forming
Any
units.
breath test?
Yeah, so it's a hydrogen blood tests are there. It's glucose blood test and lactose blood test we will do.
Okay. So with the possible history, so we have to include an infective, as ma'am said also, and Crohn's can also be one differential. So Crohn's can also present with the loss of appetite and weight, but not as tuberculosis. Then malignancies, colorectal cancer, lymphoma can also present with a chronic low-grade fever and loss of weight, loss of appetite, and loose stools. So what are the clinical features that generally differentiates with this history? Why do you want to bring tuberculosis first more than Crohn's? More of constitutional symptoms, and the onset is subacute. So generally Crohn's, not always, usually they'll fall sick on and off for many years. Generally tuberculosis goes on as a subacute this thing, and weight loss of appetite can be still there in Crohn's, but more with tuberculosis. Similarly, constitutional symptoms are more with tuberculosis. Crohn's also, they can develop fever when there is an infected perianal abscess or fistula, they can develop. Yes, ma'am. Yes.
If it's Crohn's involving small bowel, then the pain will be mainly in the periumbilical region, and
okay, how will you proceed with the investigations? So what are the specific investigations to clinch the diagnosis?
so in this, I'll start with basic blood routine
Only
investigation.
whatever is needed, the specific one.
I'll colonoscope.
You'll directly do a colonoscopy, or you want something before that? Imaging?
fecal calprotectin also.
You want some? You want a CT?
Yeah, and to see contrast and CT scan.
This patient came to me with a CECT abdomen, and an upper GI endoscopy. So her bloods were iron deficiency anemia, chest X-ray was normal. So, and if you could see the iron levels are low, and this was a CT finding. So I've highlighted some things which were seen in the CT. It had I don't have the pictures, sorry. It had circumferential asymmetric wall thickening involving the cecum and IC junction. And additionally, there was a segment of asymmetric wall thickening in the distal ileum for a length of 32 millimeters. She had multiple enlarged lymph nodes, 17 into 10 millimeter. There was minimal free fluid. There was also subchondral sclerosis with joint space narrowing, suggestive of chronic sacroiliitis. So this was the radiologist impression, query tuberculosis, query Crohn's, query malignancy. So this is to discuss what are the CT differences, very common differences. There are multiple, you can just say. And with this patient's imaging, what do you want to consider?
Since sacroiliac joint involvement is there, I would consider Crohn's as the first DD, ma'am.
But before
absence
that,
of no lymph node involvement, not much ascites, and
nodes are there.
Yes,
Nodes are almost nearing 1.7 centimeter,
yes,
almost 2 centimeter. There is minimal free fluid, not significant but minimal. Something with this asymmetric wall thickening.
Asymmetric is more in TB, ma'am.
Tuberculosis. So these are some of the important differences. In Crohn's, it's generally transmural involvement, symmetric thickening, whereas in tuberculosis, if you see generally the IC valve, cecal anatomy is all pulled up and distorted, so asymmetric thickening. This comb sign is again positive for Crohn's, whereas the nodes can be seen in both, but if you could see the size of the nodes will be generally smaller in Crohn's compared with tuberculosis. And ascites is very rare in Crohn's, whereas it's common in tuberculosis. The sacroiliitis actually fitted into the Crohn's in this patient, but predominantly she had, I think it could be tuberculosis. What is that image? What is that sign?
Comb sign.
What is comb sign?
Ma'am, prominent vascularity.
Prominent vessels in the inflamed bowel. Oh. So this patient, as she already had an endoscopy, they were not willing for an endoscopy, so I directly proceeded to the colonoscopy, and the left colon was completely normal. The left colon I could not make out the anatomy beyond 80 centimeters. It was completely ulcerated, distorted, so I could not locate the IC valve. So I've just taken biopsies from the site as well as sent it for gene expert also. So sending a biopsy for gene expert is also important. Yes.
This finding, where all you take biopsies? And what all the specimens you send, and how you send the gene expert?
Terminal ileum, IC valve, cecum, transverse colon and rectum, ma'am, to not to miss out any skip lesions in Crohn's.
What is the protocol? Whose protocol are you? What's the reference? Reference I put. Who has done a study on this?
In normal cell line. In normal cell line.
So what all specimens will you take? One is for histology. What are the other specimens?
The other is for gene expert and where location, ma'am, or what?
What are the specimens you? This is your patient. You have to take biopsy. So what are the specimens you send to the histopathologist? How many specimens would you take, and where would you take at the base of the ulcer or at the edge of the ulcer? All these questions will be asked. It's not a passing statement, you know. So all this you should know. You should know why are you taking specimens in the ascending colon? How many specimens? Huge study done by Anna Pulimun. Why do you do that? Why do you take so many specimens? Crohn's versus tuberculosis.
Skip lesions are missed in.
What will you find? You're taking so many specimens. What are you looking for in the skipped areas? What are you looking for in the skipped areas? You're sending 20 specimens. What are you looking for?
Any evidence of crypt distortion?
What else?
Granulomas, caseous necrosis or non-caseous necrosis to differentiate between TB and Crohn's.
So basically, for the
Size
interval,
of,
you're just looking for the other sites where there could be evidence of. In Crohn's, you may find evidence of colitis elsewhere, even though the gross specimen looks normal.
Yes.
Okay, just move on.
Yes.
Finish this next.
So what are the common colonoscopy differences between tuberculosis and Crohn's?
You can just finish it.
Skip lesions are usually seen with
With
Crohn's,
ulcers,
ma'am.
differences in ulcers. How about the IC valve? Two things, ulcers and the IC valve.
IC valve is patulous, maybe patulous in case of Cox tuberculosis. IC valve may be stenotic IC valve may be present in Crohn's disease, ma'am.
Generally in Crohn's, the IC valve is, in tuberculosis, the IC valve is more distorted and more affected actually than your Crohn's. Crohn's, yes, there can be a patulous or gaping IC valve, but the ileum is more involved when compared. So that is one difference. And the ulcers are generally longitudinal serpiginous ulcers in Crohn's, whereas it's circumferential transverse in tuberculosis. So this was the histopathology report, and for this patient the gene expert was detected low. So what are the histopathological differences when you come to granulomas between both the conditions?
Ma'am, in the granuloma, the size of the granuloma, first, the Crohn's will have microgranuloma. In TB there will be the large size granuloma, more than 400 micro. Langerhans cell histiocytosis will be there in.
But it can be there in both.
Can be seen in both, but.
Caseation. Not seen in all cases of tuberculosis, but if it is present, favors more of tuberculosis. So I think you have told everything. Large, confluent, microgranulomas, size. So this patient was started on weight-based ATT, and she was suggested follow-up with LFT. And the points for tuberculosis in this case were
Just
more.
1 second.
Yes.
So when will you still have a doubt? Biopsy comes as inconclusive. Here we were fortunate we got it's inconclusive, but comes as active colitis. What should you do?
Give a trial of ATT, and you can check after 3 months. Repeat colonoscopy you can check.
At what interval would you repeat? 8 weeks? 8 weeks is ideal. And then what would you do? What is extended treatment?
You can treat
What are the
both.
publications which tell us
You can
these are
treat
the
both.
outliers? 20% will still be outliers. You will not be able to pick up whether it's Crohn's or tuberculosis. In such patients, what will be the recommendation for ATT? Please read Govind Makaria's paper. It's a beautiful paper which tells you exactly what should be extended. Then the reports came back saying that 6 months is sufficient. So at the end of 6 months, you have to take a call. It's Crohn's or tuberculosis.
Okay, few questions. Why ileocecum is the most common site of tuberculosis, and what is the percentage of other sites of colon involvement in tuberculosis?
Because of stasis, lymph node involvement,
Lymphoid tissues, abundant lymphoid.
tissues involved in
Right.
ileum.
Other sites? So it's because one is for transit, slow transit, then it's generally a narrow lumen, so physiological sphincter, more common for ulcers. The other sites are cecum ascending colon 60 to 70%, transverse is 10 to 15%, left colon 5 to 10%, rectum as we initially discussed it's 1 to 2%. So what are the different forms of intestinal tuberculosis?
Hypertrophic,
Yes. Ulcerative, ulceroproliferative, hypertrophic, hyperplastic, fibrostenotic, then finally peritoneal, which can be wet and dry tuberculosis. Now, this is, as ma'am said, like this is an algorithm. How do we follow up? So, if we are in the TB endemic region, then when the diagnosis is unclear, start the patient on ATT. You should follow up. Definitely, a repeat follow up is necessary within 2 months. If the patient shows improvement, continue ATT for 6 months. If the patient does not show improvement, reconsider diagnosis, consider treating for Crohn's, or you should also keep in mind multi-drug resistant tuberculosis. So this is the final sum up of this case, showing the clinical presentation, shorter history, pulmonary symptoms, ascites, all these favors more for tuberculosis, whereas more of GI symptoms, perianal symptoms points towards Crohn's. Imaging findings, necrotic lymph nodes, patulous IC valve, asymmetric wall thickening, all these more in favor of tuberculosis. The IC valve and the cecum is more involved, whereas comb sign positive, skip lesions, long segment involvement favors more of Crohn's. The colonoscopy findings, again patulous IC valve, circumferential or transverse ulcers, whereas in Crohn's it's aphthous ulcers or longitudinal or serpingeous ulcers. These terms are very important. So histopathology, as we already discussed, the granulomas will be microgranulomas in Crohn's, whereas in macrogranulomas in tuberculosis.
What will be the presence of Behçet's disease? Behçet's.
Behçet's.
What is it and how do you differentiate? It's a very important DD for Crohn's. Just a few points on Behçet's disease. And how will you distinguish that during ileocolonoscopy?
Behçet's disease may have extra-intestinal manifestations having aphthous ulcers or genital ulcers, and they can present with thrombosis. Past history of multiple thrombosis can be there, and they generally present with a discrete, in colonoscopy they may have discrete large ulcers because of vasculitis involvement.
Granulomas and all, it's an important DD for Crohn's. So whenever you get a suspicion of Crohn's, Behçet's comes as an important DD. So just read a little bit more about Behçet's disease. Okay.
So let's move on to the last case. Here we have a 26-year-old male, chronic large volume diarrhea for 6 months. He has history of significant weight loss. He complains of easy fatigability. He has history of bilateral swelling of both the limbs since 10 days. That's why he came for hospital actually. Otherwise he was not admitted or till then. He gives history of alcohol consumption since 5 years. No other comorbids. He's not been on any medications so far. So examination, he appears pale. He has glossitis. He has angular stomatitis. He has pitting pedal edema. No organomegaly. Rectal examination was normal. BMI is 18.
1 minute. So what is missing in this patient? One important symptomatology that's not there in this patient.
Whether foul smelling.
Abdominal pain. Abdominal pain is not there. So now tell us what's the DD for painless diarrhea without abdominal pain. That's your DD. That's the DD for this patient.
Yes, ma'am.
That's why for small intestine it's only painful or painless. It can only be two. Once it becomes painless, it's non-inflammatory. Once it's painful, it's either vascular or inflammatory. That's how you distinguish. Can you give a DD for this now?
It's a small bowel diarrhea with malabsorption.
Just give a DD for painless.
It can be
watery diarrhea.
celiac disease, tropical sprue, then no, that's been. Then giardiasis,
large volume diarrhea, watery diarrhea. Giardia?
Ma'am, all the endocrine.
Keep the patient in mind, no? Alcohol consumption. Most important is you have to rule out. You have to rule out HIV infection.
Yeah.
So what are the causes
Small
of
intestine.
large volume watery diarrhea with malabsorption? What's your DD? He has malabsorption or maldigestion?
Ma'am, pancreatitis, but alcoholic, but
I'm asking you a simple question. He has malabsorption or he's got maldigestion?
So
why I'm asking all this? These are the questions that will be asked. They're just giving a flavor of that.
Malabsorption is there, ma'am.
How do you distinguish malabsorption from maldigestion?
So maldigestion, there will be the stool volume will be reduced. There will be
What's a
there
major?
will
Okay, just continue.
Yes, ma'am.
Please read all this.
So his investigations, hemoglobin was low and his total count were 9,000. MCV was low. He has eosinophils were 7%. So we did an absolute eosinophil count which was high. Peripheral smear showed microcytic hypochromic pattern. The LFT showed total protein being low 4.2, albumin 2.7, globulin 1.5. Vitamin B12 was low. TTG levels were negative. And ultrasound abdomen showed few mesenteric lymph nodes. All viral markers were negative. Stool routine was normal.
So what's the inference of low albumin and globulin? What does it state? When there's both loss of low albumin and globulin, what does it indicate? It's a protein losing state. It's a protein losing state. That this question is often asked, no? How will you know it's due to liver disease or it is small intestine? If both are lost, it's a protein losing state. So now give a DD for the protein losing state. When all can you lose protein? What are the conditions when there's a protein loss? She's already given a hint. Eosinophil counts are high. Can it be eosinophilic entropathy?
Protein losing entropathy
What
in
are the
multiple
causes
conditions
of
like
protein losing entropathy?
connective tissue disorders like
See, keep the patient
SLE.
in mind, doctor. This is your patient. We are not discussing theory. This is a patient. Okay, continue.
Okay. So, okay, I think we have already discussed this. What type of diarrhea? So, clues in the investigations, as ma'am said, eosinophilia was there.
yes, ma'am.
You
This
want to
patient has
consider something?
peripheral eosinophilia.
Yeah,
so I would consider eosinophilic gastroenteritis as one DD, ma'am.
Okay, good.
For that, we will take biopsy from the. In this case, we will take from duodenum, and there is no dysphagia. I will look for any upper esophageal involvement. If it's there, I will take biopsy from esophagus also, ma'am.
Okay.
And then I will look for eosinophil count in
So,
biopsy.
as you said, both were done, and biopsies were taken from all segments, gastric, duodenum, and things. So, this was our biopsy histopathology. Do you want to guess? Eosinophils, anything else?
Common cause for
Oh, sorry.
hypereosinophilia, no? Very high eosinophils. Worms.
Strongyloidosis.
Yes. So they could see lot of strongyloids. So it was a strongyloid causing actually hyperinfection. So when we say hyperinfection is when we identify multiple strongyloids in the sputum sample or stool sample or in the histopathology. But unlikely in patients and young individual like this without any comorbids. Generally in patients who have organ transplant or other immunocompromised state, such infections are very common. So strongyloids can present as a silent infection or hyperinfection as in this case, or it can also occur as a disseminated infection where it can spread to the lungs and CNS also. So peripheral eosinophilia is one clue for a parasitic infection, that's it. So as you said, eosinophilic can consider as one, and parasitic infections. So does this, I think this question ma'am has already asked, does this patient have protein losing entropathy? How do you know? With the LFT, everything is low. Total protein, albumin, globulin is low. So how do you confirm protein losing entropathy? Any other test, though we don't do commonly, at least.
Stool nitrogen test.
Okay, anything?
Alpha 1 antitrypsin, stool
Alpha 1,
antitrypsin
yes.
test.
So alpha 1 antitrypsin clearance is the test for protein losing entropathy.
C14.
And you want to rule out a renal loss, you have to do a urine spot protein creatinine ratio, which will be normal in protein losing entropathy. Now this patient was treated with ivermectin for 2 weeks. Albumin replacement was given and supportive treatment was given. So from this we'll just take to some questions related to this. What are some of the various infections you know which causes chronic diarrhea? What are the basic differences between maldigestion, malabsorption?
So, ma'am, one is Strongyloides torticollis, then Capillaria philippensis,
Tell the
Diphtylobacter-
common things also. I have asked infective, so you can say from bacteria or
Cryptosporidium, Isospora, then the CMV.
so you can
Shigella, then enterotoxigenic E. coli.
so you can classify like this. Even common infections you can mention. So you need not mention the rarest one, common, and then you can say in immunocompromised individuals these infections can occur. So some basic differences between maldigestion and malabsorption. So basically there will be predominant fat digestion, fat which is impaired in maldigestion, whereas patients with malabsorption will have multiple deficiencies. So that is one major difference. So we know what is SIBO, what is IMO, what are the various tests. This is just to complete the case, like these will be asked as a theory question, or if you have a case of chronic diarrhea with malabsorption, all these you have to know. Various tests for fat, at least the names and how to do the test.
Coming to a fat, we do.
What is IMO? That's intestinal methogen overgrowth. We know this bacteria, Methanobrevibacter, which is predominantly identified in IBS-C. So that's a new term which I just went through. And then you should know the breath test for SIBO also. How do you do it? You want it?
So glucose breath test and also lactose breath test. So we give glucose breath test can reach only up to the small bowel, but lactose can reach up to the colon. So we can detect
distal SIBO
also, carbohydrate malabsorption.
Okay.
Detectable, and also we can do D-xylose test. In the urine we can calculate, and also.
Okay. So I think okay. So these are the various tests. 72-hour fecal fat test, which is a quantitative test. Qualitative is Sudan stain test. For carbohydrate malabsorption, D-xylose, and for protein malabsorption, it's fecal alpha-1 antitrypsin clearance. So for want of time, I'm just not going into the test. So, but you should know at least a few lines a few steps how to perform these tests. So 72 hours fecal fat. Then this Sudan stain is a qualitative fecal fat test. When more than 60 droplets per high for field is there, it's suggestiatoria. D-xylose is mainly for carbohydrate malabsorption. It differentiates pancreatic pathology, and this is one breath test, triglyceride breath test, which is for pancreatic insufficiency. To sum up, so chronic diarrhea is defined as persistent alteration from the normal pattern, characterized by stool consistency of types 5 to 7 on the Bristol stool chart, by increased frequency and a duration more than 4 weeks. History is extremely important. So family history, drug history is very important, diabetes is very important, systemic diseases, don't miss out a thyroid profile while evaluating a patient for chronic diarrhea. Alcohol per se, when overused, can be a cause for diarrhea. So in diabetics, these are the list for chronic diarrhea. You should rule out drugs, SIBO, celiac disease in type 1, and some patients may be using artificial sweeteners. So that contains sorbitol, so that history is also important. So previous history of surgery can contribute to bile acid diarrhea or bacterial overgrowth. Physical examination is very important. So what is that picture which shows below? Where do you look for that? So you also need to say negative history. If you have a case of malabsorption, no bite hot spots, no all this is important. So where do you look for bite hot spots?
Which part of the eye?
Which part of the eye?
Conjunctive, palpebral conjunctive.
Sure. Not palpebral conjunctiva.
Bulbar conjunctiva.
Yes. So to sum up, chronic diarrhea, it can be of various etiology. So every chronic diarrhea cannot be diagnosed just with an endoscopy or a colonoscopy. So you need to, history is very important, assess for fecal incontinence, rectal examination is very important. Rule out chronic infections, think of IBS, bile acid diarrhea, SIBO, food intolerances. Then go for all the evaluation needed as per the patient's history. So still there is a confusion, then go for second line testing and keep searching for the cause. Thank you.
Thank you, Dr. Ilavarasi. A good series of cases.
Thank you.
Very beautifully taken through, and
Thank
it
you,
was
sir.
very simple and clear questions. So before we close, strongylitis, what is this test you do in stool? What do you look for in the stool? Larva or egg? Yeah, it's a larva you look
Appliform
for.
larva.
Others you look for the egg, no? In this you look for the
Appliform
larva.
larva.
That's it. It's okay.
Because
Thank you.
it grows into an adult in the small
Exactly.
small intestine.
Yeah.
So it's excreted in the stool as a larval form.
So one
Thank you,
information,
panelists.
Starbucks diarrhea, one information, what is Starbucks diarrhea?
Starbucks coffee.
Coffee, yes.
I'm not
Actually, this one is strong.
Bill of material
It's
diarrhea.
eye opener for HIV. Normally, when it's not, if you don't HIV.
It was negative, sir. This was the case when we were in